A very good morning, good evening, and good afternoon to each one of you. We welcome you to our second edition of webinar, which is on management of knee pain. I am very happy to share with you that our Zoom platform room is already filled with more than 1,000 as of now, and there are a lot of people who are in waiting. For those of your friends who are waiting to see this webinar, they can log on to our Facebook page. There is a link of our YouTube channel where they can click and watch it live out there. This webinar will be streamed live on the YouTube channel. To find the link, you can refer to the chat box and also to the Facebook page of Society of Indian Physiotherapists. Please be patient. Spend a few minutes reading out the disclaimer and important points before we start today's webinar. Thank you so much. Look forward for a great learning hour. Hi, good morning, good evening, good afternoon. I see we have participants more than 1,000 in our Zoom platform and another couple of thousand watching us on YouTube. I'm very happy to share with you this time. We have more than 7,000 participants who have registered for this webinar. Currently, 1,000 people are watching on our Zoom and a couple of thousand watching on YouTube, and it's growing every second. So once again, on behalf of Society of Indian Physiotherapists, I, Nitesh Bansal, the Secretary of Society of Indian Physiotherapists, welcome you all for this today's webinar on critical therapies on management of knee pain. Let me introduce you to our today's first speaker, who is Dr. Anil Bhave, and a well-known personality in the field of physiotherapy, not only in India, but in US as well. A practicing physical therapist for over 40 years, he evaluates and treats patients with extremely dysfunctions, for example, stiffness, weakness, joint contractures, etc., that results from conditions such as total joint replacement, limb lengthening surgery, and trauma. He has developed and patented dynamic casting and bracing techniques for treatment of stiffness and contractures. Anil is certified in various techniques such as ASTYM dry needling, kinesiological EMG, blood flow restriction therapy. An accomplished researcher and lecturer, Anil has published significant work up to 100 in peer-reviewed journals and delivered more than 330 lectures nationally as well as internationally. He is a recipient of prestigious awards such as Jacqueline Perry MD Award of the American Academy of Orthopedic Surgeons and the Lime Shell MD Award for Pediatric Orthopedic Society of North America. With these words, let me now present to you our first speaker, Dr. Anil Bhave. Over to you, Dr. Anil Bhave, and welcome to you for this webinar. Thousands of people worldwide are watching you right now. Dr. Anil Bhave, would you like to? Yeah.
So, Nitesh, thank you again for great introduction. I come to you from Baltimore, Maryland. We have been hit very hard with COVID, as you know, in United States. But we have learned a lot through it, and we will one day share that experience with everybody also. But today's topic is about knee pain, and how do we look at knee pain and how do we manage knee pain. So this presentation is evidence-based, and I have no financial conflict or benefit from this. And on the screen, you can see me here. We have never shut down our department in the United States. We still keep working on a reduced basis. We wear masks and we wear shields. Of course, gloves, and take all the precautions, but we have continued to work through this terrible times that we have had. So why do patients come to us? They come to us for only two reasons. One is to relieve pain and to improve function. That's all they come for. So how can we help them is the question. But before we go further, we have to find out where is the pain? What is the cause of pain? So I want to spend a little bit of time on that just to share with you what my thoughts are. And this is based on an article that was published a while ago on how to map the pain of the knee joint and where the pain is when you look at it carefully. And if you look at the pain, and how do you know the pain is that you have to produce pain to know where the pain is coming from, and the patient has to be awake. So people have done work on this. And let's focus on this slide for a second. This is the top-down view of the knee joint, and this is the side view of the knee joint. And here is your no sensation or no pain as 0, which is clear white, or here is a total black, which is severe pain. Now, if you look at the knee joint from the side view, which is out here, you can see that a lot of pain is in the anterior fat pad. So your patellar tendon, your fat pad are exquisitely painful, and your ACL and PCL are painful. Your roots of the menisci are painful. And if you look at it from the top-down view, you can see the posterior capsule and the synovium is painful. But if you look at the cartilage itself does not carry pain. So where is the pain from arthritis coming from then, is the question. And the question is, once the cartilage that is here gets defibrillated and gets fissured, then the subchondral pain, which is the bone below the cartilage, starts having the exquisite pain, and that's when the arthritis becomes so bad. So our job as physical therapists is to never get to that point where the cartilage then gets defibrillated and it is causing pain in the subchondral bone. So we have to catch the patient before and treat the patient. That is our philosophy at the institute that I work. So once again, the painful areas are not inside the joint. They are the bundles of ACL, PCL, posterior capsule with synovium, anterior region of the fat pad and the patellar tendon and retinaculum, and some pain in the retinaculum of the quadriceps tendon muscle right there. Those are the most painful areas. So all of this talk then is based on that principle of
Sir, your audio is gone.
Yeah. Dr. Bhave, sorry to interrupt. I think there is something wrong with the voice. We can't hear you now. Dr. Bhave, sorry to come in between. I think there is something wrong with the voice. Maybe, Dr. Bhave, can you hear us?
Can you hear me now? Everybody can hear?
I think there was something.
Raise your hand if I can hear you.
Yes, sir. We can hear you now.
Okay, so I will go back a couple of slides so that you, if you have missed the slides, I will go back again. So right here is the post-traumatic model that shows that you can have injuries in the sports area or otherwise. Here is the model. Here is the model where you have instability, and during instability, you can see, and I'll slow it down here to show you that every step she takes, she buckles in her knee, and because of that, she has pain and actually a tear of the medial patellofemoral ligament. Well, what is the instability coming from? If you do a total biomechanical evaluation in her, you will see that she has internal femoral rotation from tight adductors and hamstrings, medial hamstring tightness. She has a planovalgus foot. So we have to manage the entire biomechanical chain in order to treat her. The osteoarthritis pain is related to more medial compartment in most cases, and it can be mild to severe. Well, why does that occur? I call osteoarthritis a God's gift. We are living longer, and thus we have a problem of articular cartilage degeneration, and because of that, we do get arthritis, and we need to know how to manage it. So let's take the first audience poll and see where you're at. So at 5 degrees of varus of the knee, meaning your joint is only slightly varus, what do you think is the force on the medial condyle in walking versus a lateral condyle? And the choices are 50%, 70%, 90%. So let's give audience a few minutes to see what they think it is. I'll give time and see. I am not seeing the poll, so I am going to give an answer in the next 20 seconds. So go ahead and write the poll. I don't see the poll, so I can't see your answers. Okay, great. So the correct answer is actually the one that you didn't predict. 11% of the people only thought that it is 90%. It is actually 90%. If you look at the biomechanics of the knee, you can see that the ground reaction force vector is slightly medial to the knee joint center and thus produces a 70% load in a normal alignment. But if you are in 5 degrees of varus, which is next slide here, that shows that if you are in 5 degrees of varus, right there, you can see that almost 90% load on the medial compartment. So the take-home message is very small degree of varus will cause significant medial compression of the joint and pain. And those small degrees of varuses can be managed with better exercise therapy, including biomechanical assessment and treatment and muscle recruitment. And that is the point I would like to emphasize for all the therapists, is that when it becomes 10 or 15 degrees, it's very difficult to treat it. We have to catch them early so we can treat them more effectively. There are also other compressive models in the joint that can come from the joints above or below. And here is an example of somebody who has a equinus contracture, thus hyperextending the knee. And of course, the body weight matters. More the body weight, higher the pressure on the joint. So we have to manage that also. The next poll that we will take is, what do you think reducing BMI by 2 reduces the knee pain by? So let's launch that poll number 2, and let's get an opinion of everybody. I will give again 30 seconds to see what the panelists, what the attendees are thinking. I'll give 10 more seconds. Okay, so we got a varied poll, only 100% are seen by 7%. So what does the Farmington study show is, a Farmington study shows that by reducing BMI of 2 kilogram over minute, you can reduce the knee pain or osteoarthritis effects by 50%. So it's a very important component, and this study was done a long time ago, Felsen and all, that showed that. What about muscle strength and coordination? Very important concept that we have to remember, that a habitual limp is co-contraction of the medial hamstrings and quadriceps, and that causes increased medial compartment loads and subsequent cartilage degeneration in patients who use abnormal movement strategy. So you want to change their movement strategy and how they walk, and that's a very critical component of our management of physical therapy. And if you look at this article, it shows that just increasing the cross-sectional area of vastus medialis leads to reduced knee pain, reduced tibial cartilage loss, and reduced risk of total knee replacement. This was published a while ago in Australian Journal of Rheumatology with a 2 to 4 year follow-up. So again, muscle strength matters in terms of how we manage the pain. The last thing is about nerve pain, and the nerve pain is about peroneal nerve, saphenous nerve, sciatic nerve, and it can cause exquisite pain down the leg, also in the tibiofibular joint, because it has a branch into the tibiofibular joint, and we have to be aware of that when we treat patients. And if you look at the peroneal nerve carefully, it shows that it winds below the fibular head, and the fibular mobilizations become very important in some degree of patients. I always do the nerve glides for almost all my patients, because I believe that
there is a component of nerve irritation in all our patients, and I follow that principle. I want to just go over a little bit of my favorite techniques. And I believe that RICE, which is rest, ice, compression, and elevation, is not good anymore. We have to change the R in RICE to range of motion. An early, careful, applied range of motion will reduce pain and swelling and reduce future problem issues. So I changed my RICE protocol to now range of motion, ice, compression, and elevation. I believe in cryotherapy. I use cryotherapy, ice or cryotherapy on the joint itself and heat on the muscles. Why do I do that? Because muscles behave better with heat, and I don't care what you use. You can use many types of heating modalities as long as they're effective, it doesn't matter. And I use cryotherapy for joint because I like to keep the joint quiet and less inflamed through the process. If you see the effect of joint diffusion, it has very tremendous impact on joint diffusion. And the joint diffusion that I'm talking about is only 30 cc's, not a whole lot. But it produces almost 50% quad inhibition. So we don't want to have a joint that is effused. We have to reduce the swelling. And one of the treatment techniques that we use for that, and this is another example of patient postoperatively with pain and dysfunction due to effusion. So we like to use a very aggressive stimulation protocol as shown here. We like to see the muscle contract aggressively. The key in finding the correct electrical stimulation is one that does not cause pain, but at the same time can produce a significant contraction, which both reduces the effusion of the joint, but also pain in the joint. And there's a lot of literature on that that has been shown. So the next poll is about highest number of clinical efficacy studies on a knee therapy modality. And the choices are laser therapy, NMES with manual therapy, shortwave therapy, and ultrasound or bracing. So what do you think is the highest number of well-done studies, randomized controlled trials, or level 1 and 2 studies that are done, and which modality ranks the best in this area? Let's take that poll. And there's an article in Journal of Orthopedic and Sports Physical Therapy about this a few years ago, looking at all the other modalities that we use for knee therapy and knee pain. Well, everybody predicted right. 69% of the people said that it is NMES and manual therapy, and that's why I believe in that. I believe in that because that is the most articles that are published with NMES and manual therapy. So that's what our focus or emphasis of therapy always is. We use bracing, but we are very judicious about using bracing. We are careful about using bracing. We don't overuse the braces. We call them wraps, which are not psychological. They actually enhance proprioception. And then there are other types of braces. So braces are like a promise. You know, you give a brace to a patient, he spends a lot of money. It's like it's a promise. But babies are very fun to make, but very difficult to deliver. You have to be able to deliver what you promise a patient. So I'm very careful about my brace prescription. These are all the braces one can use, and don't discount this. This is a very useful modality for patients with constitutional varus or some instability in the knee. And then you go higher in grade as you go through and with very rigid bracing. I personally don't like very rigid bracing for most moderate to mild knee pain. I will usually recommend wraps for my patients and selectively use only unloader on patients who have medial compartment OA like this that actually get relief. And I only use these braces when there is dynamic varus. What I mean by dynamic varus is when they are walking or they're standing on that leg, they buckle further into varus. If they are getting that 3 to 5 degrees additional varus on the knee, they're going to produce more than 100% load, and then I will only use that in those patients. So I'm very judicious about it, and nothing like good follow-up. But before that, I always show this to my patients. And I tell them, I said, if the kids can wear this all day long, 24/7 for 2 years, I am sure you can use a brace for a few hours. So bracing becomes an important component as long as it's painful and it is worn. So compliance matters. So we look at our patients very carefully like this, what is the X-ray, where is the joint line, how close the joint line is. And then we use the brace to monitor, and we do like studies on it to look at how long patients wear it. So all that matters. My personal opinion on bracing is you should try before you buy, meaning the patient should go to the orthotist or brace fitter and try a few braces just like you try shoes to see what is comfortable, walk with it, and then decide what is best for them with some guidance from a physiotherapist. The last thing I want to talk about is scar tissue. Scar tissue is a very important component of management of knee pain because scar is painful and scar can be very painful. And a scar, if you under electron microscope, is a very tethered, very tight tissue that occurs after injury or surgery. I call a scar like a spaghetti in a bowl. Spaghetti in a bowl is very inflexible and it moves together and doesn't allow joint range of motion and can cause pain. Well, if you then have spaghetti in a box, which is the streamline of the scar tissue, the scar tissue needs to be elongated and stretched, and then it can be more flexible and the joint can move faster. So we use various techniques. One of them is early range of motion. You want early range of motion to promote less scar and less pain in the joint. We use several techniques. This is one of my favorite techniques called safety, which is slide and flex and tighten and extend. We use it on our patients early on to reduce scarring and pain. We use manual techniques such as soft tissue mobilization, which is shown here. And there's a whole lecture on this, and one day we can do that. And then we use certain manual therapy techniques. I'm not going to show you that right now. This is one of my favorite ones right after surgery. If you get the patient to do this after a total knee, you will never have pain or suffering from the patient in terms of scar. Then I use some manual therapy techniques. I'm not going to steal Deepak's thunder because he's going to show us the entire thing about how to do manual therapy. But these are my favorite stretches. This is a rectus femoris tensor fascia sartorius stretch. This is my distal IT band mobilization with hip in external rotation to put tension on the IT band, with rotation at the distal ankle to get the stress effect on the distal ankle. And the last thing about intensity of exercise is based on degree of inflammation. Very simple. So if the degree of inflammation is high, you start with stretching, followed by isometrics, followed by isotonics, followed by aerobics, followed by recreational therapy. It's a very simple algorithm that I made for myself and my patients to apply when we are treating patients with knee pain and inflammation. And the last thing I want to leave you with this is this video, which shows everything about knee stability and pain. This is a video about how we walk and where the forces are and how does the iliotibial band and fascia lata work. And I truly believe that if you look at this very carefully, the model here of the muscles, I believe that what we need to do to stabilize the leg and strengthen the leg is to improve strength of all that muscles that inserts into IT band. We want to reduce co-contraction and encourage a proper movement strategy and use specialized bracing, great training and NMES for osteoarthritis patients with pain. One of the movement strategies that is very useful also is if you look at rotation, if patient's foot is pointing inwards, they have more force, but if the foot is outwards, they have less force on the knee because of the way the ground reaction force vector acts on the knee joint. This is an example when the knee is internally rotated, and the previous example was in external rotation. We have been very successful with using something called blood flow restriction therapy early on to reduce pain from exercise. Because if you want to recruit a lot of muscle, you need to exercise at a higher intensity. Well, blood flow restriction therapy allows you to get strengthening at doing 30% of your 1RM. So we have incorporated that into our protocols early on. And the last thing is hip strength. There's an article, this is from JOSPT again, that shows that there are significant hip strength deficits exist in people with knee osteoarthritis. and hip strengthening matters. So we have this whole protocol of doing clamshells, standing abduction exercise, single leg bridges, and then we can add weights to it, extension of the hip. So we do this on all our patients with knee pain to make sure that the hips are strong and stable. And this is the good trunk control the knee adduction and adequate knee flexion is no pain. So this is all athletes, we will train them to do this so that they are not swaying their trunk and they have good stable balance when they do their activities of daily living. So I'm going to stop here and let Deepak take over. I will stop sharing my screen.
Thank you, Dr. Bhave. It's always a treat listening to you. And thank you so much for such a deep insight about understanding knee as a whole. I'm sure we will come back to you again and learn more about this critical therapy techniques, which is the topic for today. Thank you so much, sir. Now I'm going to ask our another speaker for the day, Dr. Deepak Kumar, to come in. Before he comes in and starts his presentation, let me introduce you. I know that's going to be a formality introducing Dr. Deepak Kumar, who's a teacher, author, researcher, clinician, and an entrepreneur, running a chain of physiotherapy clinics in Delhi NCR. He has developed more than 230 workshops and trained more than 11,000 physios, not only from India, but from 52 countries, including United States of America and Canada. Recently, he was appointed as a visiting consultant physiotherapist at the Al Qasmi Hospital in Dubai by the Ministry of Health and Prevention of UAE. He's an author of a famous book on malignant concept named Manual on Malignant Concept, which is not only bestseller on Amazon, also translated in Korean, Chinese, and Russian languages. In last 27 years, he has seen more than 1 lakh patients, administrating more than 100 professionals and supporting staff as a director, senior consultant physiotherapist at Capri Institute of Manual Therapy at New Delhi. In his name, he has many publications and best paper awards. Oh my God, Dr. Deepak, how do you do all these things? Is it only one person or there are a team behind you doing all these things?
Of course, it's always a team. We have a big team and have certified teachers with me and the staff working in the Capri, therapists and the teachers, and the support and the blessings of the friends like you. And thank you for the lovely, beautiful introduction of mine. Thank you so much. It's all your love and affection.
Thank you, sir. Thanks for accepting our request for doing another webinar, sir. So now it's over to you without taking much time. I'm sure the audience, we are 1,000 as of now in the room and more than 2,500 watching us live. So let us hear it from you. Over to Dr. Deepak, please.
Thank you, Dr. Nitesh, and thank you, Dr. Anil Bhave, all the way from Baltimore. And thanks for accepting our invitation to enlighten our physios on the knee joint. And I'm sure they gain a lot of knowledge through your experience. Thank you so much. And without spending much time, I'll directly jump into the showing the manual therapy techniques. This is in addition to all the strengthening exercise Dr. Anil has already discussed with you. So this is in addition to the strengthening exercise of the vastus medialis, strengthening of the gluteus maximus and medius, stretching of the TFL and the hams and the calf and all the other things. So what I'm going to cover right now here is only the manual therapy part of it. Okay, so let me start. And so many times you will see when the patient comes, they have small amount of fixed flexion deformity. And if there is a fixed flexion deformity, obviously the patella does not move much. But if the knee is absolutely straight, just relax. If the knee is absolutely straight, the free floating boom patella can move in any direction. But if it is slightly flexed, relax, then it doesn't move much. Okay. And Dr. Bhave already discussed that it's the fat pad which has the maximal number of nerve supply. Okay, most sensitive structure. You remember the black colors he showed for the fat pad. So it is the fat pad which get irritated. That is the one which gives pain. So first thing, I'll show how to make it straight in a pain-free way. I'm sure many people are stretching it simply, but that's very painful. So I'll show you my 5 favorite techniques, what I will do on patient. These are my manual therapy techniques. If indicated, I do it on my patients. So You need one mobilization belt, which majority of you are having, I'm sure, in your clinics. But you can use any belt, any dupatta or any cloth. You can use it. Adjust the belt appropriately and then put it close to joint line there. So I have the new model. I'm going to put the belt somewhere here, absolutely close to joint line. Okay, so I'm putting belt close to joint line and then give anterior glide. So patient is having slight fixed flexion deformity. It is there. Now I'm not going to put my another hand on the fat pad. Though you may say that it has to be close to joint line, that's true. But if I put my hand here, it will irritate the fat pad. So my superior hand goes little away from the fat pad and this comes here. And then I maintain my glide towards the ceiling. And while maintaining the glide, I push it passively down. Okay. And then you can sustain it for 5 to 10 seconds. Do it gently and slowly. Touch the P1. Do not enter into P2. It has to be pain relieving. It should not produce any type of pain. As I always say, pain is your friend, not your enemy. It tells you there is something wrong with the body. Now, next technique I would show is how to gain knee flexion. Just now, Dr. Bhave discussed gaining range of motion is one of the most important thing. And you know, when you have good range of motion, the synovial fold moves properly, synovial fluid moves properly, and the cartilage gets good amount of nutrition. Now, this knee flexion exercise I'm suggesting to do on those patients having mild to moderate osteoarthritis. In case of severe osteoarthritis, I do not recommend, or if this exercise gives any kind of pain to the patient, you probably modify the angle, direction, pressure, force. And if it is painful, don't do it. It has to be pain relieving or slight discomfort is okay, not more than that. Go gently and slowly and passively. So what I'm going to do is I'm going to take any cloth or any belt and then make figure of 8 there. And then give it to the patient. So patient is already having certain amount of joint range of motion. Beyond that, it is not going. So I have to ask patient to gently pull it. Dr. Anil Bhave also showed the same video, but in this, what I am adding is the manual therapy. So normal biomechanics for extension is the tibia should come forward, and that's what we did in the previous technique. And while doing flexion, the tibia should go backward. Okay, so this time I'm going to push the tibia backward. Actual technique is like that, but I have, over the time, I have modified my grip. So I'm going to put my palm there. Look at the angle of my forearm. That should match with the joint line of the tibia. Okay, so I'm gently pushing it backward and asking patient to pull the knee, whatever amount is pain-free. And while going, patient should give resistance through the belt, and that's it. And then again bend it. So this will help in increasing the range of motion for flexion. Why for flexion? Why we are keen for going for flexion? Because if you have the full knee bending, it gets very good nutrition to the joint. Okay, so maybe there should be another research should find out, in which you should find out if we really need to ask patient to stop doing squatting, or at least in the bed, we should allow patient to do the cross leg sitting. So they can hang the leg and they can stand up. So when they do cross leg sitting, they get good range of motion and the cartilage get good amount of nutrition. So that was the second glide, where I give the second technique, where I give the posterior glide and patient pulled it passively, and while doing it, patient gives slight resistance and she could extend. Now, next technique, which I call magical technique. In this technique, and you know, this technique I'm practicing since last more than 27 years. And I hardly see any patient not responding to this. Even if they have severe osteoarthritis, they do respond. Of course, in severe osteoarthritis, The result is not long lasting. It is a very temporary one, but in mild to moderate osteoarthritis, you get very good result. Okay, so what I'm going to do, again, asking patient to hold the knee there. One hand goes behind the knee joint, one goes in the front. Make sure you're not irritating the pes insula and serious bursa there. So, and don't use the web space, use the entire palm there, make a good grip and gently rotate internally. And then passively you are doing knee bending. Make sure you don't do knee extension first. It is the knee bending you are going to do first and then the knee extension. I'm sure you are able to make out that I'm sustaining my glide and I'm doing it passively. This should give no pain to the patient and patient will recover beautifully. But in few cases, this glide may not work. So instead of doing internal rotation, you're going to do the external rotation. Remember, if worse, reverse. Okay, so instead of keeping this grip, now I'm going to keep this grip. So instead of this, I'm doing this and then rotating it outward, again going for flexion first and then going for extension. And this gives beautiful result. But in my experience, it is the internal rotation works in majority of the cases as compared to the external rotation. Now, next technique, my favorite one, because the vastus medialis is not working, lateralis is overworking as compared to the medialis, TFL is tight, all those things will push your patella towards the outer side. And because the patella is towards the outer side, then the lateral retinaculum, that get tighter. So you need to release the lateral retinaculum and you need to go gently. You'll find the space there. You palpate the patella, and if the space on this side, outer side, is less, then you go there. That means the patella is slightly tilted and shifted. So you're going to do that very gently. Make sure there's no pain, and you can also do slight knee flexion by putting the pillow under the knee. Do it very gently. If you do it hard, you may give more pain to the patient. Make sure you do not irritate the fat pad. You only gently release the lateral retinaculum of the patella. And once you do this, next technique I would show is the mobilization of the patella. That's very easy. So stabilize the femur and gently push it. This is possible only if the person is not having FFD. So first try to release the fixed flexion deformity. So I'm going to stabilize it there and then gently mobilize the patella. Okay, I'm not going down, I'm going medially. So gently push it there, and then you can also do like this. I'll do every technique, every mobilization I'll do 5 to 10 times depending on the severity of the pain. And then I can also push it upward. I'll put it like that and then push it upward, or I'll put my thumb there and gently push it. Then I can also push it gently downward. Now, if you notice, I pushed it in all the direction, medially, laterally, inferiorly, superiorly. But just pushing medial, lateral, inferior and superior is not enough. You get best result when you push it obliquely. So I'll be pushing obliquely down in that direction gently. Again, note down, I'm not pushing there, I'm pushing there inferiorly, not posteriorly. And then again, I'm going to push it this way and then gently push it obliquely in that